Welcome, everyone. Today, we're here to discuss pharmacogenetic testing for cancer surgery and how it can dramatically improve outcomes for cancer surgery patients. This is really critical topic because when it comes to a cancer diagnosis, it's really very stressful, and we want to help ensure that patients get the most effective treatment and it allows them to be as comfortable as possible. And with me today is geneticist Ruslan Dorfman. He has extensive experience in pharmacogenetics, pain, and rare disease genetics, and he's also the chief science officer at PillCheck. And we're also excited to have pharmacist Karen Riley here with us. She'll be joining the conversation, and she brings over 42 years of pharmacy experience to today's discussion. She currently practices as a hospital pharmacist and provides community medication reviews. She also teaches in the pharmacy technician program at Lambton College, and she holds a Bachelor of Pharmacy from the University of Toronto and a Doctorate of Pharmacy from the University of Florida. She also serves as the chair of Quality Assurance Committee for the Ontario College of Pharmacists, and she's a retired clinical associate professor from the University of Florida and has published really extensively on medication management and clinical decision support systems. So thank you so much, Karen, for joining us today.
Well, it's a pleasure to be here today. Thank you.
So, Ruslan, let's get started with you. Can you help explain what pharmacogenetics means in the context of cancer treatment and why genetic variations matter so much for these patients?
Of course. So the whole term of pharmacogenetics is study how person's genetics background is affecting response to medications. And that's really critical for cancer patients because these genetic variations can affect response to chemotherapy, some nausea medications, pain medications, and overall supportive care that patients need in order to overcome this illness. Specifically for chemotherapy, there are several critical genes that we know that are metabolizing these drugs. And if people have genetic variation that slow down this metabolism, they have a much higher risk of severe complications from chemotherapy, for example, diarrhea, nausea, or sometimes loss of white blood cells that can expose them to severe infections and potentially death. So there are a couple of genes. One of them is called DPYD gene. It's the only gene so far that is covered by Ontario Provincial Program for pharmacogenetic testing for cancer patients admitted in the hospitals. And the reason is that the variations in this gene require significant dose reductions for people that carry even one copy of reduced function allele. So depending on person's genotype, there could be dose reductions between 25 to 50%, and for some patients, it might be not appropriate to use specific chemo drugs that are metabolized by DPYD enzyme. Other genes that play response to 5-FU and similar chemo drugs, they call TPMT and NUDT15. Again, the variations in both genes can affect metabolism of mercaptopurine, theoguanine, and other drugs that are used for leukemias, lymphomas treatments, and other types of cancers. And again, drug dosage should be selected based on combinations of genetic variations in these two enzymes. We also know that for breast cancer, many women would need to take drugs like tamoxifen to reduce risk of breast cancer recurrence. And tamoxifen by itself is a prodrug, is not effective. It requires metabolism in the liver by a particular enzyme called CYP2D6. And for women that don't have function of this enzyme because they're born this way, tamoxifen is absolutely not appropriate treatment because it cannot transform it into bioactive compound. At the same time, women that are ultra-rapid metabolizers, they're more likely to experience more side effects from tamoxifen. And both categories of people that are ultra-rapid or poor metabolizers, they need to take different drugs called aromatase inhibitors. Also, tamoxifen carries quite significant risk of blood clotting, and we can flag women if they have genetic variations that increase the risk of blood clot formation. So there are mutations that one of them is called factor V Leiden, another one is prothrombin variant that actually included an FDA drug label warnings about use of tamoxifen and risk of complications. So beyond chemotherapy, pharmacogenetics can truly help to optimize all therapy, specifically for people going through surgery, how to anesthesia would be performing well, and if we can optimize analgesia after surgery, and nausea is all based on person's genetic profile, and therefore we encourage people that have been diagnosed with cancer to get pharmacogenetic testing as soon as possible, because it's really important to get this information before they start first round of chemo in order to prevent really severe adverse events.
Yeah, thanks for explaining that, Ruslan. Karen, how do you see the role of PGX or pharmacogenetics in your clinical practice?
Well, thanks for that great question, Liz. So the genetic foundation that Ruslan just explained to us really translates into real clinical practice and decision making for us. And that helps prevent serious complications and definitely is involved in saving lives. So as a pharmacist working in this space and doing some consulting, I have seen the consequences of not having that genetic material available to us every day. So let's walk through just what this might look like in practice. So I am particularly interested in chemotherapy and the DPYD story. And I'll just maybe give you a personal story of why it's important that we get this right. If we get it wrong, it can lead to really severe complications. So one of my colleagues at the University of Florida actually was diagnosed with colon cancer, and she was slated to have the fluoropyrimidine therapy, so 5-FU, for the colon cancer. She started off on her journey with not even having any genetic testing. This was 2016, and so a lot of this wasn't really readily available at the time. So she received 1 dose of chemotherapy, but she didn't metabolize any of that dose, but it really wasn't identified, despite the fact she had some really severe diarrhea and some side effects. She went on to receive her 2nd dose of chemotherapy, and then that's when the toxicity really hit. So it was like she hadn't processed any of the 1st dose. Now she had the 2nd dose. So that led to a significant journey for her. She ended up being hospitalized in acute care for over a month. She had a GI bleed, so gastrointestinal bleed. She had sepsis. And in addition to that acute hospital stay, ended up in rehab for 5 months total. So 6 months hospitalization. And so if we had, prevented that with a single test, we would have, basically made her journey for her, chemotherapy much more effective. We know that if someone has that TPYD variant, we can start with reduced doses, so maybe 50% of the standard dose, and then we can monitor the patient's response. And so it's much safer to start low and then increase later than to have to deal with the severe toxicity, which really can force us to stop treatment altogether. And in her case, again, not being able to receive chemotherapy after her surgery for 6 months, within 6 months, again, so within a year of her initial diagnosis, she had to go back in for surgery to remove the tumors that grew back as a result of not having, the proper therapies. So as far as the TPMT and the NUD15 gene with the thiopurine drugs, we have similar challenges. So as Ruslan mentioned, those patients, if they have deficient TPMT function, then getting standard doses of mercaptopurine can lead to life-threatening bone marrow suppression within weeks of starting therapy. So if we proactively get those genetic results, then we can dramatically reduce the doses, sometimes just as little as 10% of the standard dose, and then that helps achieve those therapeutic levels safely. As Ruslan mentioned again, for breast cancer patients, certainly tamoxifen should be a focus of what we do genetic testing for. And that genetic testing does serve for more than just the one purpose of toxicity. We want to make sure that we're getting an efficacious therapy as well. So from the efficacy standpoint, we need the cytochrome P450 2D6 function to activate the tamoxifen. So we need to change it into the drug that is going to be active in the body. And so poor metabolizers of CYP2D6 really get very little benefit from standard doses. And in the case where there is an absent function of that gene, then we actually have to switch to totally different therapy like aromatase inhibitors. So that's the efficacy standpoint of it. So from the safety perspective, we do know tamoxifen does increase the risk of thromboembolism, stroke. And so knowing ahead of time, actually, whether or not someone is a carrier of the F2 and F5 gene variant that also increases the risk of clotting, then we can also give more or get more informed decisions with patients and determine which options are better based on not just the 2D6 but also the F2 and F5 gene. Post-operatively and chemotherapy-induced nausea is a real challenge in hospitals. So from both perspectives, but it's particularly important for those patients with cancer, because if they come out of surgery and they have non-cessant nausea and vomiting, which is really detrimental to their overall well-being, but it also decreases their hydration level, their response to their eating, so getting back with some normal habits, and even getting up and about and that early mobilization. Those are all really, really critical for patients if they're going to successfully recover from any kind of surgery. And so the standard anti-nauseant drugs that we use, so ondansetron, but there's also dalacitron, palansitron, they all actually depend on that cytochrome P450 2D6 metabolism. So if you are an ultra-rapid metabolizer of these drugs, you're just going to clear them so quickly that you're not going to get the relief of nausea and vomiting, and then you're going to have this prolonged issue to have to deal with. So again, if we know proactively, the metabolic processes surrounding the CYP2D6 gene, then we can actually switch to alternatives like ondansetron, which is not metabolized through that process. The other thing is pain control, and this is really where we're dealing with high stakes for patients in surgery in general, but especially in those patients that are undergoing cancer surgery. With the current situation with the opiate crisis, a lot of people are afraid of opiate addiction, and so they might actually try to tough it out. They're afraid of these medications, of getting them, and this also can be really dangerous to the patients as well. Because we know if we don't adequately control pain, that really increases the risk of chronic stress. It elevates cortisol levels, but it also, more importantly, decreases the immune function in the system. And so that would potentially increase the risk of cancer reoccurrence down the line. So it's really critical that we get adequate pain control within the first 2 to 3 days post-surgery. Because we know if we don't do that, then that leads to an increased risk of chronic pain that's much, much harder to control later down, the line. But we also need to know that we're sending the patient home with the right pain medication, because we don't want to send them home with something that's going to be unnecessarily high for them based on their genetic material because of the addiction risk. And so if we have that genetic material up front, we can personalize this approach completely. We know that poor CYP2D6 metabolizers also don't benefit from certain pain medications like codeine, tramadol, and oxycodone, because again, they can't actually turn those drugs into the active ingredient. If we know that ahead of time, we can switch to the drugs we know that are going to work, like morphine, hydromorphone, or even high-dose anti-inflammatory drugs. The other key thing that's important to know about, are they an ultra-rapid metabolizer of some of these opiates? Because they're at increased risk for respiratory depression. That's one of the serious side effects of opiates. And so that occurs even with standard doses. And it also doesn't give the patient a really adequate pain relief because, the drugs are being chewed up so quickly, and the length of time the medications work is compromised. So again, we can adjust accordingly. With opiates, there's also the OPRMI variants, and they need higher doses right from the start. So rather than having us guess about, what type of metabolism they have or what drugs that we should actually use, in this situation, if we don't know that, we could potentially be under treating those patients, not giving them a high enough dose.
Well, thanks for that explanation, Karen. It sounds like there's so many different applications in clinical practice, from making sure that people are getting the right treatment, the right drug at the right amount to treat their cancer effectively, but also to manage other symptoms and problems that come along with, nausea, and managing their pain effectively. Um, yeah, pharmacogenetics really helps to provide a roadmap for each patient and help avoid that trial and error approach in selecting medications. Ruslan, from a practical standpoint, when should patients be considering getting this type of testing for pharmacogenetics, and how comprehensive should it be?
So definitely the sooner the better. So right away, if people get diagnosis of cancer, in some cases, for example, for women with a familial history of cancer or Ashkenazi background, there would be a bunch of genetic tests offered, and they would be primarily looking for genetic predisposition to cancer. But these variants are not informing how the therapy should be done. So unfortunately, healthcare system is offering only one test, DPYD test, only for people that are in a hospital receiving care. And for the rest, it's up to the patient and family. So pill check is covered by workplace health benefits. People can buy it privately. And it's for the person's sake, really, it's important to get as soon as possible. Because if this information is available before the surgery, before the chemo rounds, then all the risk of side effects could be drastically reduced. Again, every drug and every chemo carries a lot of side effects, but it's really helping to avoid really significant complications that, as Karen described, it can have really bad impact on patient survival and recovery. At the same time, we had people that got pill check as after they got the surgery treatment done and after the chemo rounds. For example, we had people that were referred to us because they have depression, but they were still taking tamoxifen after initial treatment, and pill check incidentally found that they had reduced CYP2D6 function. So in essence, to make tamoxifen work better, they needed to double the dose. So yeah, still informative, still helpful, but probably it would be much better to have information sooner.
Thanks for that great summary, Ruslan. Exactly, if you're going to be doing some advanced planning, that really transforms the whole clinical workflow. From a practical standpoint, if you have the genetic results available during treatment, then the whole team can actually be involved. So this means the oncologist determining, the chemotherapy, the anesthetist knowing whether or not you're going to adequately metabolize even the anesthetic that they're going to use, the surgeons for their pain management control, and you can provide and develop a coordinated, personalized approach right from the get-go. So what I find most compelling in my practice is really how this changes the conversation between patients and their medical team. So instead of trying to be reactive and doing these adjustments after the fact and then finding out the medications don't work or they've caused serious side effects, we can proactively discuss, the best approach based on their genetic profile. So a good example would be my friend. So instead of starting on, the standard dose 5-FU and hoping for the best, we can say, based on your genetics, we're starting you at a reduced dose to keep you safe. And, here's how we're going to monitor and adjust your therapy accordingly. The psychological impact on patients is really significant too, because patients with cancer, they're already dealing with so much. They feel like they have no control over, their life as it is, but, no control over what treatment that they're actually going to get. So when you explain to them that we're really personalizing your medication based on your specific genetic makeup, that really gives them some comfort and confidence that they know we're optimizing their therapy rather than just giving them, the treatment that's, one size fits all. The economic argument is really compelling as well. So even though, as Ruslan mentioned, there's upfront costs for the genetic testing, when genetic testing first started, when we were first, teaching it to our students, there was just one gene we were testing. But now with the multi tests that we have, that gives us a whole, different view of what different treatment options that we can actually offer. We know chemotherapy-induced hospitalizations can cost tens and thousands of dollars. And so my friend was actually in the US at the time, and she estimated it was $1 million admission from acute care to chronic, care by the time she was there for 6 months. We already heard, the extended recovery from surgery because of complications of chemotherapy, but also if we don't adequately control pain control, because not only does that cost money, but it also affects, the patient's quality of life. And then we also heard, about suboptimal tamoxifen dosing. So what happens is if, if someone is a poor metabolizer, we might need to increase the dose, or we might need to switch to an alternative therapy. And then also, as Ruslan mentioned too, just even knowing what other medications the patient's taking along with tamoxifen, especially, the antidepressants and pain medications, can they metabolize those, or is there a significant drug interaction that's going to impact, the outcome of tamoxifen? And so compared to the whole great big picture, the investment in a genetic testing is going to give you this wide panel. It's going to give you loads of information, not just about, a couple of genes that you might be dealing with, but it's a lifelong roadmap. When we did our training at the university, we actually got, our map, and I was really surprised that, I have 4 variations in different genes. So from a work flow perspective, the pill check is very comprehensive. The panel eliminates the need for multiple individual genetic tests ordered at different times throughout the treatment. The other thing too is sometimes when these genetic tests have been done in the past and scanned into hospital records, sometimes they're hard to retrieve. You're not easily able to get those tests out. And initially when we were doing this, that was quite a significant factor for patients determining, their results, but also, how they were going to continue on with therapies later on. And so, if knowing upfront, what you can and can't respond to, the oncology teams can really incorporate that right from the get-go into treatment protocols. The anesthetist can pick the right anesthetic drugs for you, and then the pain treatments can be adequately modified as well.
Yeah, it does sound like having having a more comprehensive test versus individual tests and having it all in one place would be helpful from a medical management standpoint. Um, that's really fascinating, Karen. Thank you for all of your insights. Are there any key takeaways that you would, you know, highlight for our audience before we wrap up?
Yeah, so I just wanted to add that the pharmacogenetic test by itself is not enough, right? So why we work with specialists like Karen is that it's an interpretation of the test results and helping different physicians to make the right decisions about care, right? So the role of clinical pharmacists is to review pharmacogenetic test results in the context of patient situation. What other concurrent medications they're taking, and probably Karen can expand on it and explain why it's really needed. But it's really important component of our service.
Yeah, well, thanks for highlighting that, Ruslan. I think when we first started to know about pharmacogenetic testing, we actually just thought, patients are just going to go get this testing done, and then they're going to come to the pharmacy and they're going to show us what their genetic tests are. We're going to say, wow, you should use this medication and you shouldn't use that medication. But I think the bottom line now is it's evolving. Certainly the pill check multi-component tests are just amazing to give us lots of information for the patients, but we need to get that genetic testing done earlier. So the earlier, the better. And so in the case of someone, being diagnosed with cancer, like has to be done, like almost immediately or as fast as possible. So that's why a proactive approach is a little bit better. It's much easier for someone to come in with their tests and say, here's my results, rather than us trying to rush through and hope that they get the testing done in time. My friend actually did end up getting the genetic testing done, but 6 months after, which was like way too late, to find out what she already found out inadvertently, with the toxic reaction that she had. And so when we have those insights, we can really help facilitate the whole treatment journey. And also, I think it's really important that the patient has that information. They are the carrier of that information. It's not locked in a medical record someplace where they don't have access to it. As we heard, it's really important for chemotherapy dosing and drug selection, for anesthesia, for pain management, and even nausea control, which might sound, like nausea control might be something little, but it's huge for recovery. If anyone's ever had post-op nausea and vomiting, they know what it's like and how hard it is to get back on track. Second, this really isn't really rare, that it's not a rare genetic condition that you actually have these changes in your genes. And like I said, I was really surprised when I got my report and found out I had 4 genes that I needed to pay attention to, because up to 50% of patients have those genetic variations, and that can significantly affect drug response. And then the third thing that we mentioned, pain management after surgery is really critical for patients. Patients should know that we're, picking the right drug for them, that they don't have to tough through that pain when we know that it has such an impact on, potentially their survival, their cancer survival, and decreasing immune function.
Great. Well, I want to thank you both, Karen and Ruslan, for that great comprehensive overview. It sounds like, when people are facing cancer treatment, that pharmacogenetic testing and genetic testing in general is really a vital tool for helping to increase treatment success, minimize side effects, help improve overall quality of life through the entire cancer journey. So thank you for sharing your insights with us today. I want to thank everyone else for joining us, and we hope this session was informative. For more information about the PillCheck pharmacogenetic testing service and medication review, please visit pillcheck.ca, or you can email us questions at info@pillcheck.ca. Thanks again and have a great day.
Thank you. Have a great day.